Massive hemorrhage is an amazingly common event in the operating room. It could be due to trauma or assault. It may be the result of vascular disease, such as a rupture of an abdominal aortic aneurysm or a dissection of a thoracic aortic aneurysm. It may be the result of a genetic disorder, such as hemophilia. It may be drug-induced when it's secondary to anticoagulants, or secondary to non-steroidal anti-inflammatories, such in the case of gastric hemorrhage induced by diclofenac or any of the other NSAIDs that are out there. It may be due to a surgical error, when a major vessel is damaged during surgery. The treatment of massive bleeding has changed over the last 10 years. From a fairly cautious approach where red blood cells were given, and then over a period of time, if there was evidence of ongoing microbleeding or if clotting didn't seem to be occurring, you'd call for additional substances such as plasma, which has clotting factors in it, or platelets, which help form clot. We're now much more aggressive in our treatment of massive hemorrhage. And these are sometimes predictable situations such as cardiac surgery, vascular surgery, spine surgery, or it may be hemorrhage that's completely unexpected, such as when a bleeding disorder is not diagnosed prior to surgery. Your hospital should have a massive transfusion protocol that is developed jointly by anesthesiologists, surgeons, emergency physicians, intensive care physicians, and blood bank physicians. When the massive transfusion protocol is activated by the blood bank, should provide product as quickly as possible. In my hospital, when we activate this protocol, the blood bank immediately sends up 5 units of red blood cells, 5 units of platelets, and 2 units of frozen plasma. These can be administered together, all at one time, or sequentially, which depends on the acuity of the bleed and how badly things are going. And while you're giving these products, the blood bank's in the process of collecting more product to send to you. So it becomes an automatic process. You use what you get, more comes right away. If the patient has been on Coumadin or warfarin preoperatively and wasn't able to discontinue the drug for a few days before surgery, because it's an emergency surgery they're having, they should be given prothrombin complex concentrate, or PCC, to reverse the anticoagulants. And it's only 1 dose that's needed in the majority of people, and it'll reverse the anticoagulants. If heparin's been given, it can be reversed with protamine sulfate. The newer low molecular weight heparins, which have become extremely popular and are commonly used, are not as easy to reverse. We don't actually have a protocol for reversing them. And the exact period before surgery where they should be stopped has not been well worked out yet. In most cases, it's between 2 and 4 days before surgery they stop their low molecular weight heparin. Antiplatelet drugs such as aspirin or clopidogrel and non-steroidal anti-inflammatory drugs may be held before surgery, although there is little evidence that low-dose aspirin increases bleeding. And my personal preference is to continue that right up until the day of surgery. But certainly clopidogrel should be stopped about 5 days before surgery. And non-steroidals, it's controversial. And your surgeons in most cases will insist that they be stopped. If more than 2 units of red blood cells is transfused, all subsequent units have to be heated up to body temperature. And there are devices that have been designed that allow us to infuse blood very rapidly and at the same time warm it up to body temperature so that the blood going into the patient is of appropriate temperature. Excessive bleeding can occur due to large volumes of stored blood being transfused. This is known as disseminated intravascular coagulation. And in this situation, what happens is the normal clotting factors in the blood are diluted out by large volumes of blood being given without clotting factors, or even just large volumes of clear fluid such as normal saline. This is a serious complication of transfusion and of bleeding, and the patient's disease process in some cases can add to it. So patients with preeclampsia in pregnancy are at high risk of developing DIC, disseminated intravascular coagulation. It's difficult to reverse. We're hoping that the use of the blood packages that I mentioned during the massive transfusion protocol discussion may reduce this problem. It's very easy to overload a patient when you're treating massive bleeding, and you should keep a close eye on the central venous pressure at all times and be prepared to treat pulmonary edema if it occurs. Keep an eye on saturation and make sure that you're maintaining saturation. If saturation starts to drop, check the lungs and make sure that you're not filling them with fluid. So, the next thing we're going to talk about is increased intracranial pressure. Our brain is contained within a box, and within that box there are only a few substances. There's blood, there's intracellular fluid, there's interstitial fluid, which is the fluid between the cells, and there's cerebrovascular fluid, that is the fluid that bathes the brain cells within the brain and goes down through the spinal column and bathes cells within the spinal column. Any increase in any one of those without a corresponding decrease in one of the others results in an increased pressure within the cranium. And that increased pressure, if it goes to its worst level, can result in the brain, the brain stem, being forced out of the skull through the foramen magnum at the base of the skull, which is almost always associated with sudden death. Intubation by the anesthesiologist increases intracranial pressure, usually by increasing blood pressure and heart rate. Unfortunately, that can be quite a serious problem, but we can correct it by inducing anesthesia with our normal induction agents, which tend to lower blood pressure and may also reduce cerebral blood flow and increase the probability of ischemic brain damage if we drop the blood pressure too much. The careful use of anesthetic drugs to reduce pressure but maintain cerebral perfusion is a real art, and people who are neuroanesthetists spend all their time discussing this issue. Diuretics such as loop diuretics, furosemide, and osmotic agents such as mannitol basically suck water out of the cells and cause it to be lost through the kidney. So they reduce the size of the brain and reduce the pressure in the skull. How about other types of cardiac disease and cardiac arrest? We've talked about hyperkalemic cardiac arrest, but most commonly cardiac arrest in the operating room is due to ischemic heart disease. So lack of adequate oxygen to the heart muscle itself. It often is associated with patients in heart failure or patients with severe vascular disease, particularly severe aortic stenosis. Treatment of cardiac arrest in the operating room under normal circumstances should follow ACLS guidelines, with the surgeon providing the CPR and the anesthesiologist largely controlling the direction of the arrest protocol by determining what drugs will be given, when the defibrillator will be used, and by monitoring saturation and end-tidal carbon dioxide. Most important thing to do in a cardiac arrest situation is to press the arrest button and get help. They can occur secondary to pulmonary emboli, tension pneumothorax, or cardiac tamponade, or in hypovolemic shock, patients who have bled out. And these conditions have to be treated in addition to using the ACLS protocols before recovery can occur. Arrhythmias are generally treated according to ACLS protocols, with ventricular fibrillation and pulseless ventricular tachycardia treated with defibrillation. Normally, atrial arrhythmias are fairly common during anesthesia, and normally they are of no consequence, and most of the time you don't need to call a cardiac arrest if you've just got an atrial arrhythmia. So we're now going to talk about drug errors, and this mainly means wrong dose, wrong drug, and it's something that happens with anesthesiologists all too commonly, but rarely results in damage to the patient. If the anesthesiologist recognizes what drug was given in error or the wrong dose that was given, he or she should be able to adjust rapidly and correct the hemodynamic effects of that inappropriate drug. Drug errors are the most common misadventure suffered by patients in hospitals. This is a worldwide phenomenon. Huge amount of energy has gone into trying to make this a less frequent event. Current practice requires that all syringes be labeled with the name of the drug and its concentration. Drugs in a syringe must never be given to more than one patient, which is something that used to happen fairly frequently. And the use of controlled drugs such as opiates is carefully controlled and monitored. It's hoped that computerized physician entry order systems with built-in warnings to advise about possible drug interactions, duplication of orders, wrong doses, or patient allergies to a given medication will come out automatically when a physician is ordering a drug. However, despite these efforts, the commonest errors in hospital continue to be drug errors. And I must say that although it doesn't give me any pride, virtually every anesthesiologist who's been in practice for just a few years is guilty of giving the wrong drug or wrong dose on occasion. If the mistake is recognized, there is rarely an adverse event. However, if the anesthesiologist does not recognize the error or refuses to recognize the error, ignores it, damage to the patient can occur. Like anesthesiologists, surgeons also make errors. One of the commonest errors is operating on the wrong side, so the wrong arm or the wrong leg, the wrong eye. Any two-sided organs can be operated on inappropriately. Procedures are in place in most operating rooms that require the surgeon to see the patient before entry to the operating room and to mark the area to be operated upon with a marking pen. Despite this precaution, wrong-sided surgery persists. And in my own hospital, we had a case about 3 or 4 months ago with a surgeon who's very meticulous and very conscientious about marking and getting the right side. He did all that when the patient was lying supine in the holding area prior to going into the operating room. When the patient went into the operating room, she was turned prone for the surgery, and he misidentified the side and operated on the wrong foot. Fortunately, she needed the operation on that foot anyway, and they had planned to do the one foot first and then to do this other foot later, so they just ended up reversing the surgical order. But it was very, very fortunate that that in fact was the case. Surgeons can also occasionally damage tissues in error during surgery. So large blood vessels may be opened with resulting hemorrhage, or gut may be perforated with resulting peritonitis, infection in the abdominal cavity. These are rare occurrences, but they persist and are a constant concern of surgeons and healthcare organizations in general. So in summary, in this lecture, we've talked about a number of emergencies that can occur in the operating room. This is by no means a complete list, I hate to tell you. There are many other things that can go wrong, but these are things that have a direct bearing on anesthesia or surgery, and some of them, such as massive hemorrhage, are relatively common. We ended up by talking about medical error, iatrogenic disease. These things are of very great importance to all healthcare providers, and we're working very hard to reduce them. But unfortunately, as of the moment, we have not completely eliminated error in our operating rooms.